Hey guys, USMLEPOINT. Today I'm going to discuss about the important topic diabetes insipidus. This is a very important topic. Let me start. Okay, let me brief you. There are two types. One is central and other is renal. Okay, central and the renal. What is central? Central is nothing but if the cause is found in the pituitary or a hypothalamus, because diabetes insipidus is nothing but it's a, sorry for the interruption. In the central diabetes insipidus, the lesion is in the pituitary or the hypothalamus. In diabetes insipidus, there is a lack of ADH, antidiuretic hormone. So the antidiuretic hormone is not secreted, so it does not conserve the water, so patient starts losing the water, and there are other effects I'll discuss. Let's move on to next slide. Renal, it's a peripheral, that is where ADH is appropriately secreted by the pituitary, but it does not have an effect because of the lesion in the renal. So there are many causes for the renal diabetes insipidus, like hypokalemia, hypercalcemia, sickle cell diseases. There are other causes also, like sarcoidosis, Sjogren syndrome, lithium, then myeloma, other things. But let me tell you about this. Okay, clinical findings. The patient will have polyuria, thirst, polydipsia, because he is losing water because of lack of ADH, either due to central or the renal cause. There is a polyuria, thirst, polydipsia, hypernatremia. This is very important. You find hypernatremia because when there is no ADH, the water is lost, so the sodium level increases to the concentration. High serum osmolality. High serum osmolality is the same mechanism as I told before for hypernatremia. Urine specific gravity will be less because more amount of water is lost through the urine, and the patient sometimes can present with a dehydration, mental status changes. Okay, the lab findings important for USMLE is plasma and urine osmolality. This is very important. You need to do the test. You have to see the relationship. Okay, if they fall to the right of the shaded area, like a plasma osmolality to urine osmolality, if they fall to the right of the shaded area, then patient is having diabetes insipidus. So now what you have to do, you have to see whether it's a central or the renal. So what do? Which will be the next test to differentiate between central and the renal? Just give vasopressin. If it corrects, it's a central cause because there is lack of vasopressin, lack of ADH. If not, even if you give vasopressin or ADH, it's not correcting, then there is a lesion in the renal, so the ADH whatever you give is not going to act on the kidney, so kidney are not working, so the renal might be the cause. Okay, so what is water deprivation test? This is frequently asked in the examination. So what we do here is we compare the urine osmolality after dehydrating the patient versus urine osmolality after vasopressin. In a normal person like me and you, the response to the fluid restriction is to increase the urine osmolality and decrease the urine volume, right? Because we are not in dehydration, we are not drinking enough water, so our body starts consuming the water, so small amount of water is lost. Whereas if the patient is suffering from diabetes insipidus, he will be losing water even if he is dehydrated, right? Okay, ADH level. Remember, ADH level is low in central and high in peripheral. Yeah, okay, low in central because pituitary, lesion in the pituitary, they are not secreting, that's why low. High, they are high, the levels are high because renal is not acting, so pituitary thinks it is not enough, so it starts secreting in a higher amount. Okay, So now the important topic is this. You might always get confused with psychogenic polydipsia. I don't know about you guys, but I know about me that frequently I get confused with the psychogenic polydipsia. We had a history. We had a patient where, you know, he was suffering from a psychogenic polydipsia. He was admitted and we ordered the nurse not to put water bottle near him, so not to keep any water bottle. The next day what we saw was he was so crazy about the water, he went to the commode and started drinking the water. Looks funny, but with this you can remember they will give the history of mental history, like a psychogenic history. So this is very important. You need to look for a psychogenic history. Okay, whereas in a diabetes insipidus, they're so thirsty they will drink up to 20 liters of water per day. That's really huge. And second thing, you can differentiate by lab findings. Management. How do you manage? For central, vasopressin or desmopressin by nasal or IV route, give it, he will be alright. For renal, what do you do? For renal, we give hydrochlorothiazides or amyloid. Okay, amyloid. This is the important question you need to know. USMLEPOINT diagnosis by the history. You need to diagnose by history. They will give the history, presentation, polydipsia, polyuria, thirst. Okay, so you need to diagnose by the history. You need to diagnose it by lab findings. Sometimes they give short history and give the lab findings, osmolality, everything, hypernatremia, and you need to differentiate between central and the renal. That's also very important. And how do you manage? Okay, thank you so much for watching my video. Please comment, subscribe.